Hello, everyone. Thank you for having me here. I am very happy to talk about a topic near and dear to my heart, which is symptom burden in women with ALD. So for all the women in here, this talk is for you. All right, so XALD, because it's X-linked, I'm going way back now, was originally thought to be a disease that affects males, so men, boys. But starting, relatively early on in 1984, there was a study published, and over the years there have been more and more studies published to show that women definitely develop symptoms. I know I'm preaching to the choir here, but I really hope that through this talk I can show clear data that women are in some ways as affected as men, in some ways more affected than men, in some ways less affected. And it's the same disease, but it's different manifestations. Okay, so a little bit about the study aims and the study design to give a little bit of a background. So our goal was to characterize the symptom burden in women with ALD, and also to assess the prevalence of cerebral disease in women. So this is something that's not very often talked about because it's so rare, but I will touch on it briefly at the end. We did quite a few studies or parts of the study. So our site, we have 127 adult women with ALD that we studied that are presented here. Part of the study was retrospective, meaning looking at charts. Part of the study was prospective, meaning we talked to our women patients and we understood and tried to understand their symptoms and heard what they had to say. And then as a comparison, we also looked at a group of adult men with ALD. So when I talk about myeloneuropathic symptoms, so adrenal myeloneuropathy, right, here's some of the symptoms, and I'm sure a lot of the women in this room have experienced these symptoms. So pain, balance, and coordination issues, loss of bowel and bladder control, all kinds of sensory issues, tingling, numbness, pain, feelings that they can't describe, and then difficulty with coordination, fine motor, sometimes gross motor skills. Okay, so the first part of the study, we looked at symptoms and signs. So I just want to clarify for the non-medical people in here, symptoms are things that the patient experiences and reports to us clinicians, and signs are things that we clinicians do on the physical exam to try to elicit these signs that could tell us about the neurologic disease. And I paired these into groups. So for example, when patients report things like pain, discomfort, numbness, paresthesias, these are all sensory symptoms, we can look for them on the physical exam, and then we categorize that as impaired sensation. So here you can see that a lot of women, more than half, have sensory symptoms. Similarly, women tell us they have walking difficulties and imbalance, and we look for that on exam. And again, more than half the women experience walking difficulties and problems with balance. Spasticity or stiffness, same thing. We look for it on exam, and all the data point to the fact that women experience a lot of these symptoms. Bowel and bladder symptoms, I didn't put the exam part because that's for the urologist, which I'm not a urologist, for urodynamic studies, but certainly women experience a lot of bowel and bladder symptoms. Okay, so the initial symptom and sign, meaning the first symptom that women tend to experience and report to us, primarily are pain and walking or gait difficulties. A lot of women also report urinary issues, right? So a lot of women have had kids, and a lot of times they come over to us and they say, well, my PCP or whoever says that this is due to me having kids. So the picture can be a little bit blurry, but certainly women experience these three as the primary initial symptom. Okay, so this is a Kaplan-Meier curve. On the X, let's see if I can do this, hang on. You guys see that? Yeah, perfect. Okay, so on the X-axis here, this is age in years. On the Y-axis is the percent of women or percent of patients who develop symptoms. The blue line is men, the red line is women. So you can see here that women develop symptoms about 10 years after men, but women definitely develop symptoms, and that increases over time. And so this is a graph that shows that a little bit, more clearly. So the x-axis here are just types of symptoms, but I don't want you to focus on that. I actually want you to focus on the pattern of the bars. So the patterns always go up. And the left bar in each group is earlier age, the middle bar is middle age, and the last bar is like later ages. So over time, as women age, these symptoms tend to increase, and that's true for most of the symptoms here. Okay, so I want to talk a little bit about injuries and comorbidities. These are the things that we hear in our clinic and we see in our research that affect women that can be multifactorial, meaning due to many different things. So, for example, falling. This is one of the standard questions we ask women when they come in, have you fallen? And that can be due to many different things. Imbalance, it can be due to walking difficulties, it can be due to cerebellar problems, and it can also be confounded by other problems like osteoporosis, right? And then you would be at higher risk for fractures, and you get injuries from falling and require medical treatment for that. So insomnia is another one of these, problems with sleep. A lot of people have problems with sleep, and it can be due to a variety of issues, neurologic symptoms, urinary symptoms, having to get up at night to go to the bathroom all the time, restless leg syndrome, which I'll touch on briefly later. And all of these things really contribute to mood problems, depression, and anxiety. So there's a part of the mood problem that is the situation that you're in that creates a high-risk environment for you to develop a mood problem. Then there is ALD itself, and it's unclear if ALD specifically, that disease pathology, could also increase the risk for patients getting depression and anxiety. So I'm going to go through these symptoms kind of one by one. I'm going to talk about ambulation and walking first. So this is a survey we asked women to fill out, and it's about whether the disease and their symptoms are limiting their ability to walk and run and climb up and down the stairs and do these things that they need to do on a daily basis. And the pattern of the colors is going to be repeated throughout the rest of the slides. So the lighter colors are mild or not at all. So the lightest color is not at all, the second lightest a little, and then the darker colors are more affected, okay? So I think the pattern here is clear that a good proportion of women have problems with ambulation. Okay, so on the subject of motor problems, movement problems, I also want to talk about movement disorders. Without getting too much into the weeds, this is reflected in symptoms like tremors, some speech abnormalities, potentially slurred speech, or what we call cerebellar speech, which is a specific type of speech pattern. Dystonia, your hands or feet getting stuck in one position. These are all movement disorders in women with cerebral disease. And we do see movement disorders or movement symptoms in women more so than in men. So I wanted to present two case studies to you. The first patient, this is directly quoted from the chart. I took a leaf out of Katie's book. This patient's physical exam says a moderate amplitude, intermittent, irregular, no-nose cervical tremor. So this is this type of tremor, and it's fairly common. There is large, irregular amplitude postural tremor, left more than right, originating in the upper arms. So that's kind of a tremor in the extremities. And then this person also has intermittent, moderate amplitude tremor originating in the upper trunk, so in the body. Second patient, the physical exam says severe dysmetria, so that is a cerebellar finding, a movement disorder resulting from a cerebellar issue primarily. Dysdiadochokinesia, so this is when your doctor asks you to do rapid alternating movements like this or like this, and you assess for the problems with those types of movements. Cerebellar speech, as I mentioned, in this patient also had mild to moderate dysarthria, so slurred speech, and truncal ataxia. So why I present these two particular cases is that, a lot of women have these symptoms, movement symptoms, but these two women had fairly severe movement symptoms to the point where we asked ourselves, is there something else going on? Because the degree of symptoms was kind of unexpected. So what do? Being a genetics clinic, we sent more genetic testing. So we actually sent a movement disorder genetic panel for both these patients. One patient had a PARC2 monoallelic pathogenic variant. So PARC2 is a gene that is associated with early onset Parkinson's disease. But generally, patients need to have 2 abnormal copies. However, very recently, there's been a meta-analysis that shows that if you have 1 pathogenic copy of PARC2, it actually significantly increases your risk of getting Parkinson's disease. So this is now going into genetic risk factors or modifiers that could modify the ALD phenotype or clinical presentation. Second patient had a monoallelic mutation in CSF1R, which is an autosomal dominant disorder. So, but it's a VUS, it's a variant of uncertain significance. So this patient had brain MRI findings that are consistent with CSF1R related disorder, but this patient remains cognitively completely sharp as a tack, which is very uncharacteristic for CSF1R related disorder. So again, these relationships are tricky and it's hard to interpret these results. But, we need to find these relationships to be able to study them. So if in doubt, send a panel or whole exome sequencing. Okay, so moving on to insomnia. Sleep is one of the most common issues I hear from my patients. And this is reflected in the survey that we sent out. So how often did you feel that your sleep was not quiet, meaning you felt like you were moving around? How often did you feel rested, drowsy, or sleepy, and so on and so forth? And again, lighter colors generally less severe, darker colors generally more severe. So you can see that a lot of women have issues with sleep from all angles, no matter how you ask the question. Okay, so kind of related to sleep, I want to talk about restless leg syndrome because that is something that a lot of our women experience and it can severely affect people's ability to sleep. So the diagnostic criteria, it's called URGES, which is a great acronym because the number one way to describe restless legs is that you have the urge to get up to move. And sitting still makes it really, really uncomfortable. The symptoms tend to get better as soon as you get up, you feel relief, and the symptoms tend to be worse in the evening or at night, which is a problem for sleep. So patients describe restless legs in all kinds of ways. Here I stole this picture from a website that's down here, but I love it because it explains it so well. So patients have certainly said, I feel like ants are crawling on my feet. I feel itching. Itching is actually a very common one I hear. Throbbing, pulling. So another one that I've heard recently actually was a patient who had anxiety, and it was attributed to anxiety and her feeling anxious. And only later did we realize that it was actually restless legs. It was that feeling of anxiety that the restless legs syndrome produced. And when we started this patient on restless legs syndrome treatment, her anxiety actually went away. So again, the most common description is actually I can't describe it for restless leg syndrome because the sensation is so hard to describe. Okay, so there's a way to quantify restless legs and how severe it is clinically, so what patients experience, and we have a scale here from very severe to no symptoms of RLS. And so what is important to take away from this slide is that 89% of our patients, of our women patients, have moderate, severe, or very severe RLS. That is a huge disease burden, and that is really going to impact somebody's quality of life because, again, restless leg syndrome almost always affects sleep. They're very closely tied together, and if you can't sleep and you're constantly sleep deprived, that's going to really impact your quality of life. Okay, and so I just want to show some slides or show some figures showing that in our clinic, at least, RLS disproportionately affects women with ALD compared to men. So here you can see that there are more women patients than men patients who have RLS symptoms. And the takeaway on the right side of this slide is that people who have RLS symptoms actually are more likely to have all of these other issues as well. So the dark blue bar are patients who have RLS symptoms, then the light blue bar are patients who don't. And two of these reach statistical significance, but the trend is clear. If you have RLS, you're more likely to also have a lot of these other symptoms down at the bottom. And I certainly do see that in the clinic. Women who have RLS, when I do exams for them, we did this pramipexole trial, and although the results haven't been unblinded, so I don't know this for sure, but I have seen, for example, women whose exam findings have significantly improved from 1 week to another for sensory testing, which from a neurologic perspective doesn't make sense because your nerves can't grow that fast. So I wonder if the RLS symptoms, the resolution or the improvement of RLS symptoms actually allow our patients to feel better or to be able to feel better in their toes. Okay. Now moving on to depression and anxiety, which is also very common in our clinic and among women with ALD. Okay, so PHQ-9 is a very commonly used scale by PCPs and other physicians and neurologists to assess for clinical depression. And again, it's on a scale, it's a numeric scale, but also a qualitative scale for severity. And 53% of women with ALD have mild, moderate, severe, moderate, or severe symptoms of clinical depression. And I bring this number up because in comparison, only 21.8% of women in the US experience mild to severe depressive symptoms. So women with ALD are more than twice as likely to experience depression and anxiety, which completely tracks with what we see in our clinic. It's a similar story for anxiety. Again, there's the GAD-7, which is the anxiety equivalent of the depression scale. So it's to measure anxiety symptoms. And 49% of women have mild to severe symptoms of anxiety. And again, in comparison, only 19.1% of US women, these data are from the CDC, experience mild to severe, not depressive, anxious symptoms. So here it's almost, it's like a 2 to 3 times difference. So women with ALD really experience these symptoms, and it's a huge burden on their everyday life and quality of life. All right, so to better understand quality of life, this is transitioning now to quality of life, we did a prospective study, 1 to 2 hour interviews with 31 women to really understand how this disease and the social dynamics and the community, meaning the environment in which they're in, impact their quality of life, okay? So 84% reported that ALD has a negative impact on overall quality of life. And the top negative contributors to quality of life are in 71% diagnosis in a family member. And to me, that completely tracks. Generally, when I ask a woman, how can I help you? What's your greatest concern? The number one response, and almost 100% is, well, I want to know for my kid X, Y, or Z. That is 100%, like almost the number one answer I get. Then there's physical symptoms, the management of care, the impact of the diagnosis on her family, not only affected people, but also unaffected people, and also the mental health symptoms and the burden. Here I want to touch a bit about barriers to care, because this is also something that comes up a lot. So 84% of women reported facing barriers to getting the care they needed. And the most commonly reported barrier, unsurprisingly, is lack of knowledge about ALD among local providers by far. And all the other reasons are listed here to the right, but I think this is something that we can certainly work on as clinicians in this field to help educate our peers and really get the word out. Okay, so symptom management in women. These are classes of drugs that our patients take for symptomatic relief, okay? So they're grouped into pain meds, mood disorder medications, antispasmodics, so medications to relieve tightness, bladder medications for urinary symptoms, sleep medications, bowel medications, usually for constipation, RLS, restless leg syndrome medications. So at least 80% of women need at least one medicine for symptom relief. So that right there tells you the disease burden. 35% need a walking aid. 32% have required orthopedic surgery, either due to primary orthopedic issues or a fracture after a fall. 31% have received steroid injections for pain, and 16% receive Botox injections for their spasticity or stiffness. So this really just shows how much this disease impacts women. I can't say that enough here. Okay, I want to move on to women with cerebral ALD. This is not common, okay, but it's very important for many different reasons. So in our clinic, we've had 3 women with progressive cerebral disease, and it's 2.4% of all of the women we have seen, okay? And what we've noticed is that it is associated with elevated plasma C26:0-LPC in the male range and adrenal insufficiency. So here is a plot of C26:0-LPC, and if you look at the group with women here on the right, women who have ALD and no adrenal insufficiency have relatively lower levels of C26:0-LPC than women with ALD and with adrenal insufficiency. So I wanted to present a case study here. We saw or rather I should say Dr. Eichler saw a 27-year-old woman with myelopathy and adrenal insufficiency. She had bladder and bowel incontinence and motor difficulties, and she had a confirmed pathogenic variant in ABCD1. She had very highly elevated, very long-chain fatty acid levels. This was before we started doing C26:0-LPC, but it was remarkable because her VLCFA levels were in the male range. And then we did an exon activation study for her, and she had a highly skewed ratio of 100:0. And then so we did a chromosomal microarray to try to understand why her exon activation was so skewed. Remember, normal is 50-50. So 100:0 is completely skewed in one direction. And for her, it was skewed towards the X with the mutation. And so the chromosome microarray basically looks at whether a chromosome has deletions or, gross abnormalities. And it was found that she had actually a deletion on the other X, so the X without the ABCD1 mutation. So somehow her body knew that the X with the deletion was likely going to be a problem, so it shut off all of those X's, and therefore it kept all of the X's with the ABCD1 variant, the mutation, on. So she had the 100:0 skewing. That's at least our hypothesis. We don't know that for 100% sure, but that's our hypothesis. So then we did a brain MRI for her, and she unfortunately developed cerebral disease. So you can see here that she has some white matter lesions in her brain, her cerebellum especially. And unfortunately, she developed rapidly progressive and very severe disease. So at age 29, she had walking difficulty, urinary issues. At 36, she was wheelchair bound. At 39, she unfortunately became so severe, she died after aspiration pneumonia. Okay, so, in conclusion, I can't say this enough. So myeloneuropathy is common in women. Women are not carriers. They actively have disease that need to be studied and managed and understood. There are comorbidities and injuries and mental health issues as a result of ALD and as a result of family members having ALD that significantly decrease their quality of life. And symptomatic management can improve quality of life, so that we need to make access to this more available for everyone. Again, access difficulties can cause issues. So some action items, these are very broad, and each one of these action items can probably be like a day-long discussion. But things to keep in mind, healthcare access, social support for women who come to clinic, disease awareness among other clinicians, patient-reported outcomes for access and interventions, really understanding the patient experience and listening to learn what we can do to help you. And then in terms of clinical care, although rare, women can develop cerebral ALD. There are some biomarkers and some tests like exon activation that could help stratify risk. I say could or may here, because this needs to be studied more. This is very much understudied and we don't quite understand it. And again, there are other genetic and environmental factors that may alter the clinical course, as I showed in my other two patient case studies. So action items here, we screen all women for adrenal insufficiency when they come to our clinic. We obtain a baseline brain MRI. So God forbid if, things change, we have something to compare to. We do obtain exon activation studies for all women who come to clinic. That will help us understand, one, for that particular patient, potentially, but also will enable us to understand an exon activation as a phenomenon much better so that we can use this to inform clinical care in the future as well. And again, look for genetic environmental modifiers. So if somebody presents with severe symptoms or symptoms that don't seem quite what you would expect for ALD, maybe there are other factors out there. And if we don't look for them, we won't find them. So I wanted to thank everyone, but really what I wanted to say is thank you to all the women in this room. You do so much to keep your families afloat, to keep this community, and I'm just so thankful and so grateful to be a part of this community. Thank you. Questions?
Thank you Hello? Thank you so much for this awesome talk and for highlighting particularly the mental health symptoms and burden and how that relates to the physical health symptoms like restless legs and to the experience of being a caregiver. I think, ALD Alliance has worked so hard on creating some kind of patient-oriented materials for a parent's guide to ALD and kind of the psychological impact, which that one focuses a lot on, what the caregiving burden of the psychological impact of having a child with ALD is like. Do you think it would be helpful, or is there already a resource for kind of highlighting the clinical experience of women with ALD in a similar way that could be provided at the time of diagnosis?
I think that would be really helpful, yes. I think helping to normalize these symptoms is something that will, and everybody here, correct me if I'm wrong, but is something that could be really helpful. Because a lot of the times we see women in our clinic, and if they really haven't had ALD care, one of the more common things I hear actually is, people have brushed off my symptoms. So I think normalizing these symptoms and saying that this is what a lot of women in your shoes have experienced is going to be really helpful. So thank you. Yes.
Yes, and I'm thinking about, you have actually some suggestions for here are, clinical tests and care providers that could be helpful in management, and having something to bring to the primary physician and say, I need a referral for these things would be,
yes,
I think, valuable.
Yes, absolutely.
So I know newborn screening, a lot of people are like, should we be detecting women or girls, through screening? And this is kind of like pointing to, when else would you detect them if they didn't have some kind of family history that they're seeing? So I don't know, I feel like what you're pointed out here is really gonna be, it's like once we know about the woman or the baby now, that this opens up the whole, we really need to, once things settle down, come back and focus on what might be necessary for mom and all of the work. And I don't know if ALD Connect has all that information available too, but that would be really good.
Thank you. Yeah, absolutely. You know, we already see girls in our clinic who were diagnosed on newborn screening. And, you know, it's a tricky subject, right? Because how much medical, you know, interaction do they need, and how do we balance that? But I agree, knowledge is power, right? And so because we have that newborn screening, we can at least have that discussion, and it can be a decision made with the patient's family together. And of course, from a research perspective and trying to understand this disease and really getting to the bottom of it, knowledge is also power. So by doing the newborn screening and, you know, having that patient population diagnosed is so important for us to be able to do that.
Thank you for that talk. I had my own question that I'm going to bypass because this is the most action we've gotten from the Zoom chat. So I think you've got a lot of our virtual attendees very excited. So I'll get to as many of these as we think time can allow, and then maybe you and I could, okay, thank you. So the first one I'm going to address, because she's asking quite a few questions, is a woman also dealing with X inactivation. Asking about potential cures for women, specifically asking about the liraglutide or gene therapy for women. Is anyone conducting research on including women in that you know of? Looks like both gene therapy and the Minorix Therapeutics.
Yeah, so absolutely. That is something that we are looking into in our lab. So, you know, thankfully we can kind of borrow from the Rett field. There's been a lot of studies on X inactivation in the Rett field, which is another X-linked disorder. And we have a collaborator with whom we're working to push this forward, right? So this is all in the preclinical stage right now, which means we're studying it in a lab to see if manipulating X inactivation could is the key word, we don't know, be a therapy for women in the future and has therapeutic potential. And most importantly, we have to make sure it's safe in the preclinical space, but that is something that we are actively working on, and we will definitely keep everyone updated here.
Thank you. And then a technical question. Do you send X inactivation studies to a commercial lab, or do you do those in-house at your institution?
We send them to a commercial lab.
Okay. I guess given all this amazing information you presented, people are asking about things that could prevent or delay the onset of symptoms and follow-up due to the manifestation of CLD. I apologize, I'm merging a lot of questions, but they're all kind of related.
Sure, yeah. So, you know, what I tell people who come to see me in clinic is, I know this is really hard and I almost feel bad for saying this, but go out and live your life and live a healthy life and come to us clinicians and talk to us about any concerns you have about you. So I know that it is so hard to not focus on our kids, but when you come to see us for you, tell us about how you're doing, because talking about it will help. So outside of the clinic, go and live your life and live a healthy life, healthy lifestyle, meaning healthy diet, exercise, mental health, wellness, really important. When you come to clinic, talk to us and tell us what bothers you. And you know, it doesn't need to be, you don't need to think, oh, is this ALD related? Is this not ALD related? I just want to hear how you are doing, because that actually informs how I care for you. So that would be the number one advice.
Thank you. I think we're okay here. Thank you. No, 10 minutes. We're good. Thank you. I'll talk to you.